Care. So welcome everyone. This is the Northern Colorado Continuum of Care General Membership Meeting. I'm Kelly Pryor. I'm the director of the Continuum of Care. So today, I'll just kind of start. If you haven't already, please put your email name or your name, your agency, and if you are willing to, put your email in the chat. So I like to start with some background of the Continuum of Care because oftentimes this might be people's first meeting. So we're happy to have you if you have not joined us before. So these general membership meetings are really just a space for all of those of us who have something to do with addressing homelessness, some of us very directly and some of us through other parts of our work. But this is just a space for us to be together, get informed, updated, find out about funding opportunities, resources, get some presentation information. We have a presentation today that I'm very excited about, and really just try to support the regional collaboration we have to end homelessness in Northern Colorado. So with that, I want to make sure we have plenty of time for our presentation today. We have Sam Borden from the Colorado Department of Public Health and Environment here to give us a presentation on harm reduction best practices. But before we do that, I want to just give some updates and a little bit of information on our point in time count. I've had lots of people ask me about it, and so we finally have solid enough numbers that we can share out on the point in time count. So first though, some updates on funding. So the Division of Housing did finally make their decisions for the ESG 22. So ESG is the Emergency Solutions Grant. And it funds things like emergency shelter, rapid rehousing, street outreach, and homeless prevention. This year, 14 organizations in Northern Colorado received ESG, which is very exciting. We actually had 2 new grantees, so 2 agencies who'd never received ESG before were awarded. So congratulations to the city of Loveland for their emergency shelter program. And then Windsor Stepping Stones does homeless prevention in Windsor, and they're a new grantee as well. So very exciting. We had 2 homeless prevention projects funded, 11 shelter projects, 4 rapid rehousing projects, and 2 street outreach projects funded in Northern Colorado, which I don't know across the state how else folks were funded, but it seems to me like we did a pretty good job up here getting money coming in. So good work for all of you. We also, I wish I had updates on the Continuum of Care program competition that happened last year in, oh my gosh, I'm trying to block it out. It was August and September and October is when we submitted our 2 applications. So the first one was a special notice of funding that HUD released to address unsheltered homelessness about maybe a month ago or so. HUD did make some funding decisions on that, and unfortunately Northern Colorado was not funded for any of our projects. I'm not, there was quite a few continuums of care that were not funded at all. Actually, several states didn't get any projects funded at all. There was quite a few large cities that didn't get funded. So I don't think it reflects on us at all that we didn't get chosen. They did say that there was like a potential for them to make a second round of awards. So I have not heard anything on that yet, but I will keep y'all updated if for some reason they change their mind. Because I do think we had some pretty strong projects that we submitted, including we had a resource navigation project, a collaborative street outreach project, and I think it was some data a data project that we submitted. And then the regular annual continuum of care project or program competition that the continuum of care oversees every year. They still have not made decisions on that for this year. So I wish I had updates for you, but I don't. So once we know though, I'll send an email out. Any questions on either ESG or those continuum of care program funds? All right, let's see here. Okay, so next here I want to transition and just show you some of our point in time count numbers. So I will preface that this is, we have not submitted these to HUD yet, and so they probably will change slightly, but these are generally the numbers. So let me share my screen here. Second. Okay. Can you all see that? Any nods? Yes. Okay. I'm assuming yes. Okay. So the point in time count, just a few kind of points about this. So the continuum of care is responsible for implementing a point in time count every year. This is required in legislation. So all across the country, this is happening around the same time. It has to be in the last 2 weeks of January. We did our point in time count on January 23rd of this year. It's a count of people who are sheltered and unsheltered, people experiencing homelessness. This year we used a combination of HMIS, which is our shared data management platform. So many of our, like a good number of our agencies that are serving people experiencing homelessness use the same platform for all of their data, like client files and things like that. And so we're able to use that, pull the data from there, and we don't have to actually survey individuals directly on the night of the point in time count. But we also did direct surveying primarily of folks who are either not, who are staying outside or were accessing, well, primarily people who are staying outside, and then others, some agencies that don't use HMIS also did some direct surveying. So this year, we surveyed in the Greeley-Evans area, Loveland, Fort Collins, Estes Park, Fort Lupton, Berthoud, and Windsor, which I was very excited about, that we expanded our coverage of the point in time count. So in Estes Park, Berthoud, and Windsor, that was the first time we've ever really counted anyone in those towns. And then in Fort Lupton, it was the first time we've done an unsheltered count. And we'll show the numbers, but it's pretty cool that we've been able to expand, because we want to show to HUD that it's not just the 3 main cities in Northern Colorado that we've got people experiencing homelessness. So one of the things we also did was we improved just general strategy and coverage of our unsheltered count. So we had more coordination around having people go out, survey folks. We used an app this year rather than paper surveys. And so that, I think, affected some of the unsheltered numbers. I will say we have not done any analysis. So this is not to say things are higher, they're lower. There's, we're not drawing any conclusions yet. I will be releasing a full report with analysis as soon as possible, hopefully in the next month or so, month or two. That'll have more than just the point in time count included in that report. But that is kind of just some information background before we show the numbers here. So let's see. So preliminary point in time count numbers. I'll just let you all take a second to look at this. So the total number is higher than last year. I think, again, we have not done an actual analysis, so I can't say for sure, or percentages or things like that. I think the factors that we really want to make sure we are thinking about when we're looking at these numbers is we did survey in more places. We increased our ability to count. And so I think it could very well be just we're continuing to get better at counting people. And I mean, also just a plug, I think we all kind of understand the point in time count. It's helpful to a degree. It's also one night out of the year. So this is just a snapshot of homelessness. So this is usually point in time counts are undercounts for sure. So. All right. Are there any questions or anything around the point in time count that folks have?
Kelly, I have a question. So the chronic in the second graph at the bottom, so the word chronic, so are those unique? Are they included in other subpopulations?
Yeah. That's a good question. So no, so the chronic, veterans, and youth, these are included inside the single adults and families with children. So they're not separate.
Thank you.
Yeah. So, and families with children, this is the total number of people. So this is including children. It's not just heads of household.
And Kelly, what is the TH? I'm just not drawing a blank.
Oh, yeah, that's a good question. Transitional housing.
Okay.
Transitional housing. So
my brain's not computing.
Yeah. That's a great question. Thanks for clarifying that, Paula. Transitional housing. Shelter is so it could be the most common is a traditional emergency shelter. It also included domestic violence like safe house shelters, or if someone, I don't know if we actually had this, we might have a few. If someone was getting like a motel voucher for the night, that also was included in sheltered. Transitional housing are those longer term programs where people still maintain their homelessness status, but they are there for a longer period of time. And then unsheltered could be outside in a car, in some other place not meant for human habitation. All right. So like I said, we will be doing a lot more analysis. Last year we did a kind of racial and ethnic disparities analysis. We'll be doing that again with our point in time count show kind of comparison year over year. But then we also have lots of other data sources, and so we'll be pulling that all together in one report. Okay. Great. Well, with that, I am going to, I think I saw Sam on the line. So I'm going to turn it over to Sam Borden. She's with the Department of Public Health and Environment, and I will let her introduce herself more.
Great. Thank you so much, Kelly. Good morning. Thank you so much for having me today at your meeting. I'm going to go ahead and share my screen so you can see what I'm talking about today. All right. So like Kelly mentioned earlier, we're going to be talking about some harm reduction best practices for serving people who are unhoused or experience some level on the continuum of homelessness. Obviously, this is not going to be a comprehensive, all-encompassing look, but hopefully we can touch on some elements that are helpful to you. My ask would be that we just save questions until the end, but please feel free to put your questions in the chat, because I know that they leave my mind the second that I kind of pass the opportunity. So feel free to drop them there and I will address them at the very end of the presentation. So my name is Sam Borden. My pronouns are she, her. I am the Harm Reduction Grant Fund Manager at CDPHE, so I'm housed within the Overdose Prevention Unit. My specific role is to act as a subject matter expert on harm reduction for the State Department, and also to help grantees across the state establish, continue, fund programs that support harm reduction in their specific communities for their specific populations. A little bit of background on me. You can see me dressed up as a vial of naloxone here for Halloween. That's just a little treat for the morning. So my background is in some direct service harm reduction. So I used to manage a syringe access program actually up here in Northern Colorado. So I worked directly with people who use drugs. I provided sterile syringes, sterile smoking equipment, naloxone trainings. I worked with people experiencing a variety of housing and other circumstantial life experiences. And so I'm drawing a lot from my own personal experience. Obviously, we all have different environments that we're working in, different experiences, different backgrounds. So know that I'm coming in with a narrowed down view. So it may not be applicable all the time to what you have kind of experienced. My major topics that I'm going to be covering today are going to be the overdose epidemic, some drug use and drug basics, a quick understanding of harm reduction as a philosophy, and then some practical strategies, including some tools for responding to emergencies that might arise. So some basics on substances. There are so many different substances, and we know at this point, and really throughout history, the illicit drug market is unpredictable because it's unregulated. We're just going to kind of focus on stimulants and depressants today, but I also want to note psychedelics are also within that sphere. So when we're talking about stimulants, we're talking about amphetamines such as cocaine, crack, methamphetamine, prescription medications such as Adderall. And when we're talking about depressants, typically we're going to be talking about benzodiazepines, which would be something like Xanax, alcohol. We're going to be talking about heroin or opioids in general, including fentanyl. We know that psychedelics and other substances can cause situations to arise in your setting. And so we can also talk a little bit more about that at the end if that's something specific you want to address. So one major thing to remember when we're talking about substances is that polysubstance use is extremely common. So polysubstance use really leads to this synergistic effect where 2 + 2 = 7 rather than 4. So just because you know how alcohol is going to affect you and you know how heroin's going to affect you, when you combine the two, you're going to have a very different effect. And that varies from person to person. When you combine 2 depressants, that obviously enhances the risk of overdose. When you combine a stimulant and a depressant, that can also enhance the risk of overdose or kind of adverse reactions, because we know that stimulants last a little bit shorter period of time. So if someone's co-using, that stimulant drops off, that depressant's still trucking. And so that's when we may have a later or delayed overdose reaction. When I'm talking about polysubstance use, I'm also talking about prescribed medications. So even combining alcohol and say an SSRI, like an antidepressant, that could have that synergistic effect. So really being careful about how we time our substance use can be a helpful piece of information for our clients, for our participants, and for ourselves, honestly. Route of administration also really matters. So route of administration has many different kind of types and flavors. We see injection, smoking, snorting, eating, drinking, vaporizing, and booty bumping, if that's an unfamiliar term for you. Really, people will use mucous membranes throughout their body to use drugs. There are different levels of risk for each of these methods. We're seeing a lot of transition into smoking with the rise of fentanyl in the illicit market, which actually is a risk reduction technique, despite the fact that fentanyl is tremendously more potent. All right. Excuse me. So tolerance can change rapidly, and this is something to be in tune with when you're working with individuals who have had a brief period of abstinence or a longer term period of abstinence due to incarceration, cessation of use, entering into detox or rehabilitation. So when someone, especially when someone leaves incarceration, their risk of overdose is exponentially higher than the average population. It really only takes a couple of days for your tolerance to significantly drop. And so if someone leaves incarceration after maybe a weekend, they use the same amount that they were using before, they may have a really intense reaction that they didn't experience prior to that cessation of use. So it's a good thing to kind of check in with people about in terms of what's your plan now that you've left jail, or now that you've kind of moved out of that detox facility. How do we kind of manage your risk if you decide to resume use? Our mindset and our setting also play a huge role in how we experience substance use. So this really comes into play when we're talking about day shelters or overnight shelters, when we're talking about any sort of place where people might be in a congregate setting. So some drugs, the impact is pretty calming or pretty neutral. But if you're seeing someone who's on maybe psychedelics or a stimulant, being overstimulated can happen very quickly. And so having those environmental factors, not only including the space that you're in, but also maybe you're experiencing heightened stress, heightened anxiety, you're having a trauma reaction, all of those can really affect the way that substances end up working for you that day. And so really having that kind of trauma-informed approach and that environmental consciousness around the spaces that you're creating for individuals can be a helpful way to make sure that you're preventing any sort of escalatory effect. So I just really want to quickly touch on fentanyl and some of the other emerging synthetic opioids, because I know this is deeply in the front of our minds right now. It's been all the news, it's been all on social media. And so just want to kind of bust some myths and give you some basic understanding. So because the illicit market is constantly changing and adapting, we do see these emerging forms of drugs that are trying to kind of subvert the increased criminalization, increased kind of enforcement. The illicit market, just like the licit market, is economically driven. And so the ways that it changes are meant to make sure that there's no economic losses based off of any sort of changes in the drug supply or in the criminalization of each kind of area. So with fentanyl, it is significantly stronger. It's about 50 times stronger than heroin. It was originally synthesized in about 1960, just to be created to have in a hospital setting. It's an incredibly helpful tool for reducing pain, especially in palliative settings. And then we started seeing it kind of emerging in the illicit market as well. Some of the reasons for that especially are that because it's so potent, it has really helped people kind of expand their supply. So you see originally sort of like heroin cut with fentanyl. Typically it's added to illicit opioids. We've also seen some cross-contamination with benzodiazepines, with cocaine, with methamphetamine. The thing about having multiple white powders is that sometimes when you're cutting them on the same table, there is some cross-contamination that occurs. I do want to emphasize again that the illicit market is economically driven. It is not economically advantageous to kill your customers. And so when you hear about people intentionally trying to poison or add fentanyl to their drug supply, it is not something that we typically see done maliciously. It's something we see done unintentionally. When rainbow fentanyl emerged, we saw a lot of fear around that being marketed towards young people. Again, not economically advantageous to sell drugs to children. They don't usually have a lot of money. They don't have a high tolerance. And again, we're not trying to kill our customers. Typically, we see these changes occurring because we're trying to, again, subvert those kind of criminalization aspects. So trying to kind of fly under the radar, and also to try and kind of warn our customer base that, hey, this is a different color because it's not cocaine, right? So one of the major differences we're seeing with fentanyl is that the onset to the physiological effect of overdose happens much, much quicker. And so originally with heroin, we saw about a 5 to 30 minute kind of range for that entry into respiratory depression. With fentanyl, that's happening within 0 to 2 minutes, depending upon the person's tolerance. And so you're really seeing this progression on this chart to cardiac arrest much faster. And after cardiac arrest starts to occur, naloxone becomes a less potent tool for responding. This really emphasizes to me that it is so important to have naloxone on site. It's also really important as a bystander to carry naloxone. My constant comment is I just keep it in my fanny pack or my purse when I go to a concert, when I walk down Colfax, when I, am out in the environment, because oftentimes bystanders and people who use drugs are going to be the first responders to the opioid epidemic. Some common myths that we hear is that fentanyl is naloxone resistant. Fentanyl is an opioid, just like heroin, just like oxycodone. It will come in and sit on those receptors and bump the opioid off, giving that person a chance to resume breathing. You don't need to dose someone with 12 doses of naloxone at the start.
Good morning, neighbor to neighbor. This is Trish. How can I help you?
So what we encourage is that you continue to follow the same protocol. So give someone 1 dose of naloxone, wait that 2 to 3 minutes for that naloxone to take effect, give rescue breathing if that breathing is stopped in between, and then dose with another dose of naloxone if necessary. If that person starts to regain consciousness, you do not need to give them more naloxone. I know it's an emergency situation, it's chaotic, it's traumatizing, but really giving time is important. And with that kind of entry of things like veterinary tranquilizers like xylazine, rescue breathing becomes incredibly important. So does CPR if pulse is no longer there. Overdoses are also not caused by incidental contact. So this has been a really hard myth to bust. Honestly, where the danger comes in with this myth is that people are afraid to respond to an overdose because they're concerned that if they touch a substance, if they walk into a room with fentanyl, if they get close to that person, that they could potentially experience an overdose. Fentanyl is only the cause of an overdose if it is smoked, snorted, or eaten. I don't recommend doing any of those things if you walk into a room and spot some strange powder or substance. You can see this picture up top. This was a great accidental experiment that someone conducted. They poured accidentally liquid fentanyl over their hand with some small abrasions that had no negative effects. Typically what we're seeing when we're seeing these types of viral reactions, especially as first responders, is we're seeing panic attacks. That's not everyone's favorite thing to admit. When we suspect harm is about to befall us, our body can have a pretty intense physiological reaction. Our breathing speeds up, we may pass out. These are very legitimate responses to fear. However, they are not an overdose. Fentanyl is not in every drug, so that's something that you'll be hearing a lot of times. It is certainly pretty much replaced all heroin on the illicit market at this point. However, it is not in illicit substances. For example, it's not in marijuana. It's not in prescription medications that are, prescribed by a doctor. However, we do see it cross-contaminating other depressants. Couple things to know about things like illicit marijuana or vaporizer pens. If you apply fire directly to fentanyl, it will be destroyed. So you see people smoking from a glass bulb or under foil, and vaporizers just do not reach the level of heat that is needed to vaporize fentanyl. So fentanyl's boiling point is about 700 to 800 degrees Fahrenheit. Most vape pens get to about 400 degrees Fahrenheit, and that's not tremendously comfortable at that level. So we're not seeing that as a phenomenon here in Colorado. And then finally, some people do use fentanyl knowingly. So if someone's using illicit opioids, that's their option at this point. And people have found ways to increase harm reduction around this practice.
However, risk is always going to be a factor when consuming illegal drugs because it is almost impossible to ensure purity, and it's not something that's moderated by any sort of governmental body. So, a quick overview of the overdose epidemic, particularly here in Colorado. These numbers are from 2021. Our 2022 numbers will be coming out around probably May. But in 2021, we lost about 1,200 individuals to overdose deaths. 749 of those, those were 1,258 overdose deaths involving heroin or other opioids. We saw 749 overdose deaths due to methamphetamine or other psychostimulants. So that number has been steadily rising and is something we need to keep in our minds in terms of the risk there. And 60 overdose deaths due to alcohol poisoning. So alcohol remains a factor, certainly, in overdose deaths. One thing to know is that we get our data from death reporting on death certificates. So we're not always getting a full picture because of the delay in toxicology. Some coroner's offices just don't have the resources to assess for fentanyl or other substances when they are looking at a death that may be accidental or unusual. And so we estimate this is a significant undercount. Below, you're going to see the cause of death from the Colorado Coalition for the Homeless. This is specific to Denver. However, you see that overdose accounts for about 50% of those deaths. There's obviously other drugs represented on here as well in terms of alcohol. And you also see other kind of environmental factors playing a role. So really just looking at one factor limits our understanding of the issue. We know that being unhoused can certainly contribute to higher risk, higher vulnerability to overdose. And oftentimes individuals may be using substances to survive outside. So if it's really cold, stimulants can be a helpful tool to keep you walking around so you don't lay down and freeze to death, keeps you alert so you're not assaulted or lose your things. For opioids, illicit opioids help people manage pain, help people relax in extremely stressful situations. We have to kind of look at that bigger picture of substance use so we can see where our clients may be coming from in terms of their use. Like I mentioned before, we are seeing almost an entire transition to synthetic opioids on the illicit market. So the difference between an opioid and an opiate is that opiates, like heroin, are directly derived from the opium poppy plants, whereas opioids are synthetically produced in a laboratory setting. They are much cheaper to produce. They bypass the effects of climate change on the opium poppy, and they are incredibly more potent. And so, whereas we may have seen earlier in the opioid epidemic, this narrative around overprescribing, which is a limited narrative, with prescription medication, and then that heroin piece coming in when those prescriptions cease, we are now seeing people using synthetic opioids at much higher rates because that's what's available to them, and they get a little bit more bang for their buck as well. So, jumping in, what is harm reduction? So I assume this may not be a super new topic to many of you, and luckily we're seeing more and more discussion around harm reduction in the public sphere, especially in public health. It's not always been well accepted by public health, but it is something that was created by people who are most affected by elements such as homelessness, sex work, drug use, HIV, AIDS. You can see up here that I've included a picture of a jacket that was created by David Wojnarowicz. I don't know if I can pronounce his name correctly, Wojnarowicz, that really emphasized that kind of ACT UP movement where people were living with HIV or AIDS, and they were really fighting for ways to improve their health without much aid from the federal or local governments. So harm reduction incorporates a spectrum of strategies, including safer techniques for substance use, managed use, and abstinence. So abstinence is on that continuum of harm reduction to promote the dignity and well-being of people who use drugs. It's also a framework for understanding structural inequalities like poverty, racism, homophobia, classism,
And it's really important to meet people where they're at, but we try not to leave them there. We try and give them tools, empower them to kind of take control of their own harm reduction, because we know that people are the primary agents in their lives for reducing harm. You may have used harm reduction this morning when you drove to work, so you may have worn your seatbelt. That's harm reduction. We know motor vehicle accidents are extremely common, and so using your seatbelt was a form of harm reduction. We can't just stop driving, unfortunately. You may be aware of sexual health tools such as condoms. That is harm reduction. You may have experienced wearing a mask over the last few years several times. That's also harm reduction. And so harm reduction recognizes that life oftentimes inherently contains risk, and there are ways for us to keep ourselves alive and keep others alive, even if it doesn't create the perfect conditions that we want. So we recognize that people will continue to use drugs for multiple different reasons, ranging from to have a good time to deal with some pretty difficult issues. And so we want to make sure that they live to see another day, even if we would prefer that they don't use substances. Another piece of this, which I'm sure you all use in your work already, but we really want to emphasize person first language. So a person is a person first, and a behavior is something that can change or fluctuate over their life. So terms like drug addict, user, imply someone is something instead of someone. We know that stigma is a barrier to care, and we can pretty much accurately tell someone what we think about them just through some simple words. People are allowed to self-identify. So when I worked directly with individuals, they might call themselves an addict, or they might call themselves a junkie. However, my language reflects what I'm trying to convey to them, that I see them as a person first, and that I'm here to work collaboratively with them to get them into a place where they feel their substance use is manageable. People are more than their drug use, and harm reduction focuses on the whole person. Again, bringing in those aspects of looking at the socioeconomic factors of the impacts of racism, homophobia, classism, houselessness. These are all important to get a full picture of how we can reduce harm. So I apologize for the chunk of text on this slide, but I wanted to make sure I was covering quite a bit here. So when we're talking more specifically about the kind of principles and pieces of harm reduction, we're talking about a few different points, and I'm going to return to these when we're doing practical strategies in a little bit here. So health and dignity is an aspect of harm reduction. We are establishing quality of individual and community life and well-being as a criteria for successful interventions and policies. So quality of life doesn't say abstinence, doesn't say necessarily being housed. We know both of those things can reduce risk significantly. How do we establish or increase quality of life within the confines and the limitations of the resources available to us at hand? Participant-centered services is a huge part of this. So it calls for non-judgmental, non-coercive provision of services and resources to assist individuals in reducing drug attendant harm or other attendant harm of their circumstance. Participant involvement is always going to be a huge and important strategy for everyone who works directly with individuals or even kind of builds programs. We want to ensure participants and communities impacted have a real voice in the creation of programs, in the sustaining of programs. We know harm reduction came from the people most affected. It was created by marginalized communities. And so these people know what they need, and we need to listen because they'll give you a wealth of information, not only about how to develop programs, but also what they're seeing in their environment. We got tipped off to fentanyl, and we get tipped off from other drug trends directly from people who are using drugs. Participant autonomy is a huge element. So affirming that participants are the primary agents of change, and we seek to empower them. Sociocultural factors absolutely come into play. So we recognize the realities of various social inequalities, and they affect how they affect people's vulnerability and capacity to deal with harm. And then we also live in a realm of pragmatism and realism. Harm reduction does not condemn or condone substance use or other behaviors that might be risky. However, It is certainly in place to kind of recognize that there are real and tragic pieces of harm that might come in to play with these substance use. However, that we are looking to minimize that harm. So these are, I know we have a little over 60 folks on this call. So these are more kind of rhetorical questions for you all, but really some things to reflect on as we go into the next few slides. So when you're thinking about harm reduction, what harm reduction strategies or de-escalation tactics you already use? So if you're in direct service, what do you kind of use when someone comes in agitated, or when they're experiencing withdrawal and they're arguing with staff, or when maybe an argument comes in off of the street into your site? What are the different de-escalation tactics that you already use? And then when do you draw the line? So there are black and white scenarios, and then there are gray scenarios. One example of this might be a service ban versus a service pause. And so just kind of thinking about your internal policies, you know, what you're seeing, where those lines are drawn. Obviously, it's going to vary from place to place. And part of creating a welcoming space also makes sure that we are drawing boundaries and expectations, so we're keeping all of our participants safe. And that may lead to some difficult decisions and difficult conversations. So, jumping into practical strategies, I want to just really emphasize here again that I do not stand in your shoes. I do not work in the environments that you work in. Some of these thoughts, practices, strategies may not apply. So take what helps and leave the rest. You are the experts in the work that you do. And so just want to kind of give that disclaimer before we jump in here. So obviously, that being said, you need to understand your environment. So you know which clients you work with. You have some data, for example, that point in time data that Kelly was going over. You know your community and the resources available to you, and those resources may be incredibly limited. So that is an area that you have to contend with. Recognizing our personal bias is a huge piece of the work that we do. When I come into a space, I come with a fair amount of baggage around substance use. You know, I've experienced substance use disorder myself. I have lost friends and family to overdose or substance use related causes. And so I'm led in a big old suitcase into the spaces I enter with other clients. However, I have to recognize that my experience is not theirs, and really maintain a little bit of a poker face, some compassion, and just check my biases. We also want to recognize that you all probably experience some vicarious trauma from time to time. Yeah. And that has a huge impact on our ability to do this work. So we really need to make sure that internally, in terms of our policies, in terms of the supports that we're providing to employees, that we're attending to the vicarious trauma. People have that baggage, which may be triggered with working with people who are experiencing chronic stress, chronic trauma, social inequities. And so things like putting in place clinical supervision, regardless of someone's standing or their certifications, can be really helpful in providing that tool so people can process what they're hearing, what they're seeing, build up their self-awareness and personal growth, and really gain some of those clinical skills. I encourage, again, everyone to ask for participant feedback, whatever that looks like to you. So that might be surveys, comment box. You'll always get some interesting responses in there. Never a dull moment. Or having kind of focus groups or a client advisory board. These can be really great ways for you to build connection and community for the people that you work with. And then obviously establishing healthy boundaries is going to be paramount. So when we're talking about harm reduction, we're not talking about overall permissiveness, right? We have to make sure that our participants, our clients, the people that we work with, our staff, our community has a clear idea of what the expectations are around our services. These apply if you're in a management position, if you're in a frontline position. We really want to look at our policies. We want to look at our materials.
You all will walk away from this and have a better understanding of how it impacts your policies and whether or not those need to be audited. So jumping right in, like I said, we're going to be talking about mostly psychostimulants and depressants. However, we can address some of those other substances later on if you have questions. So psychostimulants such as methamphetamine, cocaine, can have a shorter acting effect, certainly more than most depressants. And so redosing is really common. People will use multiple times a day. They may be injecting, they may be snorting or smoking. And so that's just something to know, because that shorter acting term can make behavior less consistent. Some potential escalation factors may be euphoria, paranoia, fear, and people contend with these emotions very differently, right? So some people may experience fear and shut down, others may experience fear and lash out. A lot of times this is tapping into our fight-flight response. One of the overdose risks for stimulants is called overramping. And so overramping means a lot of different things to a lot of different people. It can just be as simple as our body's just not feeling right. Could be psychological, paranoia, anxiety. It also can be physiological. So we see rapid heart rate, overheating, dehydration, impulsive behavior that might put them or others in danger. When mixed with other substances, this can really increase the risk of something like cardiac arrest. Unfortunately, there's not something like naloxone to respond to something like benzodiazepines, which is a depressant, or psychostimulants like methamphetamine. So medical attention is necessary. So again, we're setting clear expectations. Try another day. So you see a client come in, they're extremely agitated, they're using substances. Can we tell them, hey, I recognize that you're experiencing something here. Why don't we try another day for this service? We want to kind of agree upon times to de-stimulate. So that may be having a conversation with your client saying, like, you know what, I know you use substances. I know you redose frequently. We have an appointment at 2 p.m. What does it look like for you to kind of de-escalate 30 minutes before that? And then we can plan for you to go and redose as needed on your own time in your own space after our appointment. That's not a perfect negotiation skill, but once you've built rapport with a client, you can kind of set those expectations really transparently. Some tactics for de-escalation, which may or may not be achievable depending upon your space, is providing a cool, empty, neutral space where there's not a lot of people accessing services. Having one-on-one interaction can be really helpful if someone's amped up. However, we do want to make sure that you're keeping yourself safe as well. So being attentive to, whatever support is near you, letting your other staff know what's going on, all very helpful. Having a rapport with your client can be huge. So when I worked with clients at the Syringe Access, I would have folks come in extremely agitated, but they saw me and they knew that I was a friendly face. They knew that I cared about them, that we'd had, many good, meaningful conversations. And so when I took them back to have a conversation and get them what they needed, we were able to kind of talk one-on-one. They may have still been amped, but they could at least sit down and calm down a little bit. And then we want to remain calm. We can validate their experiences, but if we get escalated, it does not help them de-escalate. So really making sure that we're kind of mirroring the behavior that we want to see. For safety, we want to make sure that person is never alone and that they have an exit route. So if they are overamping, if they're having impulsive behavior, if they have a rapid heart rate, just making sure that we're keeping an eye on them. Sleep, water, and nutritional drinks are all important tools. Even some chocolate milk that you have on hand can be really helpful in terms of just giving someone some nutrients while they're using, because we know that amphetamines can certainly reduce appetite. And then if you need to move the conversation indoors or outdoors, that can be helpful to give some options to your client.
All right, so depressants are typically longer acting. Fentanyl actually is a little bit shorter acting than heroin. So we see about 2 to 4 hours versus potentially a little bit longer than that with heroin. So redosing is a little bit less common. The potential escalation that we typically see is confusion, unconsciousness, respiratory depression. Side note here that people can use depressants or stimulants and be pretty stable. Oftentimes, especially with stimulants, I had clients who came in very escalated, and it turned out that they were not using amphetamines. In fact, those amphetamines were stabilizing for them. There's some complication there with no longer being able to access prescribed medication because of drug use history that you might actually need. There is an extreme overdose risk with depressants, especially for mixing substances. So that could be systemic depression, vomiting, dehydration, unconsciousness, and lack of breathing. So we want to, again, set clear expectations. How can staff support? What's our role, basically? Where are we going to intervene? When are we going to kind of sit back? Are we going to let this person kind of sit in the waiting room or sit in this space and just like nod a little bit after using? Or is that something that we need to talk about, not being in our space? I want to make sure we're being attentive to our other clients as well in terms of triggering them, in terms of making them feel safe. Keeping monitoring in place is really important. So keeping someone who's at the front desk or near any sort of bathroom space where someone might be alone is really important so that you can respond to an emergency if necessary. So that might include implementation of bathroom checks. You want to have a sharps container on site or it's outside the building. And then naloxone on site, absolutely. With depressants, withdrawal can be particularly vicious. You typically don't die from withdrawal from opioids. It is very painful. However, benzodiazepines and alcohol can have fatal withdrawal effects. And so if you see someone who's experienced extreme withdrawal symptoms, getting them into care is vital. We know those resources don't always exist. So even if you're able to get them to the hospital so they can have that kind of titration off the substance, you may save their life. So just so we can kind of reflect quickly on the signs of an overdose emergency, typically that person is not able to be woken up. Their breathing will be slow or absent. They'll have a slow heartbeat or a low blood pressure. If you have a pulse oximeter, you can check their O2 level should not be below 90. That's a little bit more, kind of technical equipment to have on site, which you may not have. The skin feels cold and clammy. Their pupils are very small, and their nails and lips are blue or ashy, depending upon how much melanin they have in their skin. These signs are also common with benzodiazepines or alcohol. One of our best tools is to lay someone into the rescue position so that if they vomit, they will not aspirate on their vomit, and that's just pushing them on their side so their arms are propping them up. When in doubt, administer naloxone. If you can get someone to wake up with a sternum rub or just kind of a loud voice, you do not need to administer naloxone. They may either be experiencing some other type of emergency or just be in a heavy nod. If someone is experiencing another type of emergency and you administer naloxone, that's fine. It's not going to help with that other emergency, but it will not hurt them. So some practical tips based off of some of those categories that we talked about earlier. In terms of kind of focusing on health and dignity, we're going to try and have affirming messages and materials and have accessible bathrooms. Bathrooms are huge, and we know that it adds an extra layer of complication around having to check the bathroom, but being able to access facilities in a space can be really dignifying for an individual because we see more and more of those restrooms being denied to them. Participant autonomy can be increased by having supplies and resources accessible without staff permission. There are limitations to this, obviously, but you can negotiate that within the context of your own space and allowing individuals to come and leave freely. Participant-centered services would be offering what participants say is most important. So do they need access to chargers, phones, computers, water, bathroom? What does that look like for them? You may be able to provide what they ask for, you may not, but asking is always helpful. In terms of attending to sociocultural factors, having multilingual resources and multilingual staff is really important. Posters that explicitly state that all people are welcome and other messaging around, and a variety of images in the space. So making sure that the people that you're serving are represented when they come in. Participant involvement is a great way to build rapport, to build de-escalation kind of scaffolding with clients, because they're going to kind of come to see the space as theirs. So creating message boards for participants to contribute feedback or share resources with others. Elections for services and space changes. So kind of getting that buy-in in terms of what services you may be thinking about providing. And then really opportunities to get involved. When I was serving people who use drugs, they constantly wanted to volunteer. They wanted to be able to serve their community. And so that is also a great way to build up that participant autonomy, health and dignity, is making sure that there are ways for individuals can get involved. So that may be just as simple as, hey, do you want to serve coffee today to the other participants? These can be great ways for folks to take some ownership in their services. And then again, pragmatism and realism. So consider posting community agreements in a public space, creating alternative spaces for people who need to be moving around, be alone, pace. That might be an outdoor space, that might be an indoor space, and there are obviously limitations to this as well. So again, a little bit of a rhetorical question. How can you apply harm reduction to your space? How can you kind of preemptively prevent escalation? There's going to be different situations that arise that will challenge you in ways that you haven't anticipated. You know this, I know this. And so making sure that you are able to have conversations with staff as well, do that kind of review of how something went, how could it have gone better, what policies do we need to change, how can we affect our environment. All right, so that's the bulk of it. I do want to touch on funding resources for you all. There has been a little bit more attention being paid to that kind of cross connection between substance use and housing disparity. Obviously, we know that substance use doesn't necessarily contribute to losing housing, and not everybody who is experiencing homelessness is using substances. However, like I mentioned before, it can be a way to cope with the chaos, the stress, and the environmental concerns of being homeless. So a couple of local resources can be found through the Colorado Department of Local Affairs. They have consistent posting of their current funding opportunities. The Daniels Fund covers a few different regions, including Colorado, and they have applications accepted on an as submitted basis. So that's a rolling fund. You don't necessarily have to wait for a term to apply, and they do focus on housing and substance use, along with other issues such as aging. There are grant announcements typically put out through the Behavioral Health Administration. They're going to focus a lot more on that kind of treatment capacity on the substance use piece. And then we also have federal resources, which obviously come with their own limitations and can be much more competitive and harder to apply for. CDPHE, where I'm at, typically has multiple different funding opportunities across branches. I've linked the page where you can see which ones are currently open and active. If you are interested in joining any sort of newsletters that we have around health equity, around overdose prevention, around youth prevention, please feel free to reach out to me and I will get you connected, because we typically do post funding opportunities in those as well as they arise. And then another resource for you all is the Colorado Consortium for Prescription Drug Abuse Prevention Grant Writing Assistance. So if you are an organization that is absolutely strapped in terms of the work that you're doing and you just do not have the capacity to write grants, the Colorado Consortium on a yearly basis so far has been providing free grant writing assistance through a grant writing pool. So please feel free to utilize that if you are at your maximum and you just cannot have that capacity to write grants. couple of additional resources. So obviously SAMHSA and the CDC are national level resources. So they do have some resources specifically on mental health and substance use and the crossover into homelessness. There are some housing first and harm reduction resources that I've linked here. There's also a homelessness learning hub that I've linked that includes a free harm reduction training if you want to kind of continue this learning process. The National Harm Reduction Coalition is the mothership of harm reduction here in the United States. You can find numerous resources, toolkits, how-tos, step-by-step guides, flyers on that site. They specifically have some information on homelessness and harm reduction. And then the National Healthcare for the Homeless Council also has some information and resources on harm reduction. Again, not comprehensive, not all-encompassing, but just a good place to start if that's something you want to explore more extensively. Obviously, we kind of touched on the overarching or attendant pieces of substance use, but there are practical strategies such as providing supplies, distributing naloxone, that are very direct service when it comes to harm reduction. That can certainly be something you consider. All right. I am going to go ahead now and pause for questions if there are any. And I will absolutely share this slide deck with you so that you can access these links and review back.
Thank you so much, Sam. As you're all thinking, if you have questions, I know I have one. In case any of the folks on the line do not have naloxone at their place of work, can you share anything about how they might go about getting some?
Yeah, absolutely. That's a great question. So within the overdose prevention unit, there is the naloxone bulk purchase fund. The list of eligible entities has just recently expanded, but we can provide naloxone at no cost to nonprofit entities, to a variety of different spaces. I'll happily link that in the presentation, or when I send the presentation out. I can absolutely add information on that. Basically, the process to get involved, if you're not already, is to get a standing order, which you can get through the state or through a local provider who can be your signatory authority. And then you will apply for the bulk fund. And then my wonderful colleague, Jericho, will try and help you through that process to make sure that you can order and receive naloxone. You then can provide that naloxone to clients or have it on site. And we can also provide more intensive naloxone training as a resource to anyone who wants to start using this or having this resource around.
Awesome, thank you. And then do you know if for those that do have it already, does it expire?
It's a great question. So there is an expiration date as well as a temperature range on naloxone. What we've been able to find is that since naloxone has been around since 1970, which is kind of wild, there's been time to study how long it's still effective. And we're seeing effectiveness past about 30 years. So you may have internal policies where you don't allow use after expiration. That's fine. I really encourage maybe giving some of those expired naloxone kits to something like a syringe access program, because I will distribute them. It's also very hardy past the temperature range on that box. It's been frozen, it's been thawed, and it's still been found to be effective. And so that is something that you can certainly keep in your car. It's something that participants can keep in their backpack. You know, obviously not everyone has access to a perfectly temperature and controlled environment. So we want to make sure that everyone has access and they can still carry it. There is legislation that does protect you if you use naloxone and it's expired. It's part of the third-party naloxone statute. And so you are protected from any civil or criminal liability if you administer naloxone in an event that you suspect to be an overdose, from any sort of kind of tertiary issues that might arise. Good Samaritan law is also in place. So if you call 911, if your participants call 911 and they participate with first responders, stay on the scene, administer aid, then they should not be charged with paraphernalia or small levels of drug possession. There are some caveats there, especially with fentanyl, with the new legislation adding more criminalization layers to that. But I can certainly go more in depth on that if you would like.
Thanks. Lisa, I see your hand up.
Hey, Sam, I had a question about the causes of death slide that you had.
Sure.
Was that one kind of multiple questions? Was I right that it was specific to people experiencing homelessness in Colorado?
So this is total, the numbers above, and then the figure 3 is people experiencing homelessness in Denver specifically. So that was about 200 folks. So yes, Colorado wide, this is going to be total. Yeah.
And then my second part of that was, like, I think that there is I have been told this and heard this, that you can't overdose from meth. And I'm wondering if you can talk about that a little bit.
Sure. Yeah. So with methamphetamine, and really any other substance, when we're talking about overdose, it's at its face, taking more of a drug than our body can handle. And so with methamphetamine, because our systems are so stimulated, that's when we start seeing things like strokes, we start seeing things like heart attacks, tachycardia, like system overheating. So that's where causes of death really come into play. It's going to be that opposite end of the spectrum where our body is just kind of at critical operational meltdown. Whereas with depressants, we're seeing that respiratory depression and lack of breathing.
Yeah, that makes a lot of sense to think about it that way, with the depressants kind of just making everything stop, that the meth or stimulants in general, just like so overstimulated doing what your body does, that the stroker, that makes sense. Thank you.
Yeah, of course, no problem. Great question.
Are there any other questions for Sam? I'm seeing a lot of awesome presentation comments in the chat. So
thank you so much for having me. Obviously so much more to kind of be explored with this. If you have any questions, want additional resources, want to discuss your environment in particular, please don't hesitate to reach out to me. I'm happy to either provide technical assistance or get you connected to someone who can do even a better job than I can.
Great. And I will, just so y'all know, Sam's going to get me the PowerPoint, and I'm recording this meeting. I'm thinking what I'll do is cut out just the presentation part of the meeting and post that as well. I have had a couple people ask to have it so that they can share with their staff. So it'll take me a little bit to do that, but I'll get that done for you all. So great. Well, thank you, Sam. You're welcome to stay on if you'd like, but you do not have to. We are going to transition and really just do some updates, partner updates, get a sense of what's going on in Northern Colorado related to homelessness. So before we do that, does anyone have any questions or anything they'd like to share prior to us going into partner updates? All right, great. Well, we'll do this kind of in sector. So we'll start with shelters, day centers, street outreach, kind of direct service for folks experiencing homelessness. If you can give updates. I know we have some shelter closures coming up for the season and things like that. So just feel free, raise your hands and we'll go through them. Paula.
Yeah, so on April 2nd, the first Sunday of the month, that will be our last sleep in our chapel area. And then that Monday, it will be closing down. So that means we'll be reducing our shelter capacity by 18 to 20. So And then our winter shelter will be closing down on the 16th. So the 17th will be our last breakfast.
Okay. And that's at Fort Collins Rescue Mission, yes?
Yes. Yeah.
All right. Okay, Sean.
Yeah, hello everybody. So the United Way's seasonal cold weather shelter will be shutting down in a month, April 15th. So April 14th into April 15th is the last night that services will be available. So there won't be an overnight congregate sheltering option in Greeley through the summer, which always happens because we always close around April 15th. To date, we've had 402 individuals enrolled in that shelter. We're working with community partners, City of Greeley, Catholic Charities, Salvation Army, and some other community partners to just prepare for the influx of people spreading throughout the community, and then getting people housed through the Housing Navigation Center, transitioning when possible. So yeah, that's our big update for sheltering.
Thank you, Sean. And is the day shelter, and I guess this is a question for Paula as well, as the day shelter part gonna be open at all, or is that also closing?
Say that again.
So, I guess I know for Sean, for the Housing Navigation Center cold weather shelter, they have a day space. Is that also closing?
No, the Housing Navigation Center day shelter will continue to remain open through the summer, Monday through Friday, 8:30 to 4.
Okay. And then Paula, FCRM still day, do people have to leave at a certain time, or are they allowed to be there during the day?
Yes, so our reserved guests are able to stay there during the day, but our overflow is always had to leave at 8 a.m.
Okay. Thank you.
You're welcome.
Deb.
Good morning. We have, I currently have 2 openings for 2 families. We can get 3 to 4 in each room. So if anybody knows a family, they have to be under 18. Kids have to be under 18. So give us a call if you. I'll put Hope at Miracle House in Fort Lupton. Sorry.
Great. Thank you. And I think you put your email in the chat I saw earlier, so.
Yes, I'll put my phone number in there too.
Great. Mark.
Good morning, everyone. My name is Mark Fortin, Master Social Worker, Centennial Board of Cooperative Education Services, into Homeless Assistance Act on a regional level, Runaway and Homeless Act. So we have a street outreach grant program and always reaching out to youth, 21 and under, and types of manners. So always open concerned about and sort of actions. We also operate the 21-day emergency shelter under the RIA, Runaway Homeless Act. So it's typically with host homes. And with that funding and opportunity for a young person 12 to 17 years of age, we have an additional other housing rent stay programs, some up to 18 months transition. And also the Department of Housing host home, which is a 6 month. I'll put my contact information. It's always interesting thoughts on having. So again, for youth. Thank you.
So, thank you, Mark. Delaney, I saw your hand up, but then it's down. Do you have something?
Hi, this is Jessica Fiddler from Almost Home, and I'm going to just speak on behalf of Delaney. She's her Zoom isn't working the greatest. We just wanted to let everyone know we will have a part-time housing navigation position that will post on Monday for Southern Weld County. So just to keep an eye out for that and share if you know of anyone who might be interested in that position.
That's great. Allison.
Loveland is a few weeks away from opening what we refer to as the South Railroad site, which is humanitarian tents. We'll start with a capacity for 35. We are working on what we will do for people who are unable to make it to that site or unable to stay there for one reason or another. Maybe they're in a wheelchair, et cetera. And so we'll have some overflow capacity, but we still, our basic capacity right now is 32 people. And it's not going to increase by a huge amount. We've been sheltering quite a few people in motels, so we will release those people. We'll exit them from motels within the next few weeks, a few people a week over the next few weeks, and see what happens to our capacity. I think that it would be a great idea if we could regionally come up with a way to communicate via shelters about what's happening with capacity, knowing that places are closing and opening, et cetera, just to be able to find a way to keep in touch with, we know that a lot of people are going to go back to camping and what that means in each of the cities and what that looks like, what elected officials are doing, et cetera. So Kelly, maybe you and I can talk offline at some point to figure out how we can keep all of that information current with all of us. Thanks.
Yeah, that's a great idea. And I'm if anybody's interested, I would imagine it would be helpful for everybody, but you can always mark that in the chat and I can follow back up with you. Question, Allison. So when you said South Railroad sites opening for a capacity of 35, does that mean the LRC is no longer going to be used as a shelter, or is it both?
You know, it's hard to say right now. We still haven't finalized that. We need a place where people can go who are in wheelchairs. So we're also talking about using a room at our library.
Okay.
Those spaces will still have capacity issues because likely those spaces, especially if we use the library, will only be available for people with mobility impairments. So it won't necessarily be pure overflow. So we'll be figuring those things out in the next 2 weeks. Yesterday, early, like at 3 o'clock, I thought we might be starting as of April 3rd and or about 2 o'clock, and by 3 o'clock, I think it might be April 10th, but we're getting close. And Dylan, do you have anything to add? Dylan Cruz, our shelter director, is on the line.
Hi there, thanks. I just wanted to add that we are also hiring, shocker, social workers also hiring. We are looking for a part-time overnight shelter position, as well as we are looking for a full-time shelter position. So if you have any staff members or any people you know who want to dip their toe into this work or establish in this work and want to get into Loveland's resources, we'd love to have them apply. And yeah, I think that's all I have to add. Thanks.
Thank you. Lisa.
I just want to say Project Homeless Connect, which is the Fort Collins Resource Fair for people experiencing homelessness, is happening on April 14th at the Northside Otsalon Center from 10 to 2. I imagine many of you will be there yourselves or have staff doing tables, but it is a time shift. Usually it's 8 to noon, but we're doing 10 to 2 this year. So we won't be serving breakfast, but we will have a lunch. If you want more information, you can put your name in the chat and I'll make sure that you're connected to that. But just a reminder that that's happening soon.
Thank you. Emily.
Yeah, so at Family Housing Network, we do have 2 openings in our overnight program. We also do have access to use our day center for those who do call our main number and do a phone screen and then ultimately an intake with me. So we are specifically we do support families experiencing homelessness. For those who might not know, but currently I do have 2 openings and with day center access with a phone screen and intake with me, which could deter people, but hopefully not, and intake with me.
Great. Emily, could you put in the chat the number to call for a phone screen?
I forgot to say that. Absolutely.
Thank you.
You bet.
And Joe.
Yes, so in Larimer County, we are fairly close to capacity. We're about 120% to capacity in single women, 100% for families. We can flex. We're not turning folks away. We still have some spots in our extended stay program for men in particular and vets. In Greeley, our extended stay program is getting fairly close to capacity, but again, we want to find a way to say yes. And especially as we've had these weather events this winter, we've been really leaning into embracing providing emergency shelter for women and families. And we're going to continue to do that. And just need to reach out to Mark Howie. And again, we will find a way to meet the needs for the community in Greeley.
Thank you, Joe.
You're welcome.
Okay. Any other day shelter, street outreach, other emergency shelter, victim service shelter, or like domestic violence shelter? Any more updates on that? Okay. We'll move to housing. If there are any housing providers, really anything related to housing, any updates? I believe, I'm not sure if Connections is on the call. I know the Connections for Independent Living wait list for housing choice vouchers is open through the month of March. So that's for Greeley, or that's for Weld County. So folks can refer people to their website, Connections for Independent Living, to get details on that. Gia.
Sometimes I can't remember which category I fall under. I think this is me.
Yeah, you're good. You're good.
Cool. Hi, everyone. I just wanted to let you know a few updates. We are looking for a property manager. So if you all know any good property managers that would be interested, could you please send them our way? And then I also wanted to let you all know that our screening process that we added to our program is going very well. The only question that I hear often from our partners in the community is, do they have to be behind in order to get eviction prevention assistance now? They do. They do have to have been served a demand for compliance or an eviction notice. Why? Because so many people right now are getting served these notices. We have to prioritize those files anyway. And so we're looking at helping those individuals who have that immediate urgency. She's doing that on purpose. And so I also wanted to let you all know that I am actually leaving Neighbor to Neighbor. I'm moving back to Georgia. And so my last month will be in May. And so I'll definitely be sending out emails and saying my goodbyes. I know I worked with a lot of you. I've enjoyed working with a lot of you. I love this community. It's just time for me to go home. And I just wanted to let you all know.
Thank you, Gia. And that's Neighbor to Neighbor. All right. Let's see. Looks like a few folks have put things in the chat. I will, Jillian, as far as Connections for Independent Living, I can send out the contact information for that. All right, other housing, any other housing updates? Any updates from our city, county government, local government partners?
Kelly, I guess this is when I go. I'm not sure because I'm Weld County now.
Yeah, you can. Go for it.
So kind of not really updates, just now that I'm orientating into this new position, there's just some things as I'm going through this that I'm focusing on in regards to the CoC. As I'm navigating into this position, I'm really trying to look at the criminal justice side of it and really connect to just looking at kind of exits that are considered unstable or homeless, trying to get some data points on numbers. I'll be overseeing the community corrections and alternative sentencing here. So I'll be doing a lot of policy and procedures. I'll be doing a lot of navigating service connections, a lot of the contracting. So as I've been in this, I've kind of just been asking questions and gathering details a little bit on how homelessness relates to it, kind of data points, numbers, seeing what percentages of people are coming out of transitional settings into homelessness within the community. We also work directly with, parole, the probation, the courts. So it's kind of giving me a really good opportunity to just have multiple resources and sources to get some of this information generated. So I think that as far as this position, that's kind of where I'm directing at right now as I'm still orientating. There's a lot of pieces to it. So kind of trying to learn the different roles that I'll be playing with that. And then just really focusing on how that connects to the CoC funding and different things like that. So just kind of wanted to update everyone on that and just kind of give you an idea. So if you have any questions or thoughts on things that you think would be good to bring to me and kind of look at, since now I'm in Weld County and I'm working with a lot of different agencies that surround more criminal justice through Weld County. And I'm also working directly with Weld County through just some of the commissioners and different things. It's a really good opportunity to get a little more information on that. So if you have anything that you would like, to talk to me about, or something you'd like to help me, that you would want me to help you look into, definitely feel free to contact me and get a hold of me. But that's kind of where I'm at with my role right now and relating it to the CoC.
Awesome. Thank you, Kendra. Lisa.
One more thing I wanted to throw in. It's not directly our update, but it is kind of connected. So the city of, Fort Collins Police Department has started a new team called the HOPE team. I think it's Homeless Outreach and Proactive Engagement Team. And it's kind of being formed now. Sergeant Annie Hill, many of you might have met. She was a co-responder for a long time. She's the lead on that team. And it's something new that's happening in Fort Collins. And they'll be focusing more on issues related to safety and enforcement. This is kind of from the conversations we've heard, and not taking over what our outreach program does, but I do think we'll be doing a lot of work in conjunction with them. They've called us for situations, even though the team is still kind of being formed, to step in when people need support before encampment cleanups, a variety of things. So it's a cool new thing happening in Fort Collins. Just want to make sure people knew about it.
Thank you. Yeah, I think that's a good transition. If there's justice system, public safety, any of those updates too. But Sean. You're muted.
I lowered my hand instead of unmuting myself. Yeah, so I don't see Juliana or Corinne here, so I'll give kind of an update in terms of Wellsway Home partnerships with the city and the county. In terms of housing case management, we're pretty excited that the city of Greeley's gearing up to launch their homelessness to housing case management team. So they're hiring 5 case managers with 60 housing vouchers attached to focus on people experiencing chronic homelessness. Get them directly into housing and really do some housing first processes effectively. So that's going to be great. It's about half of the people experiencing chronic homelessness at the shelter currently. And 5 people that essentially doubles the case management for housing navigation. And then Weld County, their street outreach team has hired 2 housing stability case managers that I believe started last week. I just met them this week, and they're also helping to keep people housed through their emergency rental assistance program. So we're really excited to see that expanded case management here in Greeley and Weld County to help people get housing specifically. So yeah, just want to share that.
Yeah, that's great. Okay. Christine, go for it. You're welcome to share.
I had to unmute first. Good morning, everyone. This is Christine Sorbana, and I'm from the Northern Colorado Faith-Based Organizing Committee, a part of Together Colorado, and truly appreciate being a part of this group. Although we don't provide any services, we really need to know who's providing those kinds of things to our homeless. Homelessness is part of our work. But what we do, however, is push for systemic change and policy action. And I just wanted to apprise you of 2. There's about 15 bills now before the legislature, and 2 of them are really relevant to sustainable, affordable housing. And the first one is House Bill 23-1115, which is repealing the ban for rent control. And the other one is 1171 that deals with just cause eviction. So there's 2 before the legislature. 1115, the repeal, is now before the Senate. It's moved out of the House. So if you're interested at all in supporting our efforts to support those bills, send me an email, and I can send you a link where you could send an email directly to your legislator. So yes, thank you very much, and really be pleased to be part of this group, and I laud all of your efforts. Thank you.
Thank you, Christine. All right. Do we have any information or updates from youth services? We also want to go into veteran services, and then healthcare, behavioral health, mental health, medical care, and any of those.
Kelly, you said youth services, correct?
Sure. Yep. Go for it.
Awesome. So for the Matthews House, you may have seen or already know that the youth shelter is underway in Larimer County for Loveland. So the hope is for that to officially open in August of 2024. So we still got a long ways to go, but it's coming pretty quickly. Also, Matthews House, our host home program is transitioning out, and we are transitioning to a rapid rehousing program for young people, 18-ish up to right now, I believe it's up to 23. So we're just starting that transition. So more updates to come in the coming months as we hit the ground running in getting that program implemented. So those are the updates from the Matthews House.
Thank you, Kim. All right. Also, any other youth, or also we could do veteran updates, really special population, like if you have a focus area population, feel free to provide your updates. Laura.
Hi, everybody. My name is Laura. I work with Volunteers of America with our SSVF program. We are getting ready to wrap up our grant year, and also May 11th, the Stafford Act is no longer going to be in place. And this was an act put into place when COVID hit. So funding will be changing pretty significantly for our SSVF programs. We'll still be actively working with veterans in the community around housing stability. So if anyone has any questions, you're welcome to reach out to me, but we are actively working with vets to try to get everybody set up for success when when our restrictions come back into place for funding.
Are you able to say just a little bit like the highlights of what the changes are going to be?
Yeah, so when COVID hit, the VA essentially gave us a lot of money and said, just keep people safe and healthy away from COVID. And we were able to not have restrictions on our rental payments. And so those will be going back into place once the Stafford Act ends on May 11th. So the SSVF program does have limitations on funding and what that looks like. So those will come back into play.
All right. Any of our mental health, behavioral health, healthcare providers, any updates or information? All right. And then anyone else that I did not make space for, any other information anyone would like to share with the group?
Hi all, I can jump in. I also never really know when to chime in. So Kylie Hipschman, she, her, hers from United Way of Larimer County. And so just a quick update for the group that I'm going to pull up really quickly from our team. So the Emergency Food and Shelter Program awards will be announced the first week of April. The application is currently closed, but review is currently happening. And then as well in the housing space, we're continuing to explore the best ways to show up when it comes to policy and advocacy. We are connected to several organizations in the community that are thinking about having some community events for Fair Housing Month, which is in April. So stay tuned to learn more about some community events around fair housing, as well as some community messaging about the importance of preserving and increasing access to safe and affordable housing across our community. So I will drop my email in the chat in case you or your organization would love to get involved. I know some of the folks here on this call, their organizations are already involved with some of the work that we are starting to explore and develop as a community, but just want to say thank you for the work that you all are doing. We're so grateful to partner and are continuing to explore how we can address some systems level change that is necessary to increase access to housing. So that's all I've got. Thank you.
Thanks, Kylie. I'm in talks with someone from the Denver Fair House. It's like a Colorado Fair Housing Association group that they're going to come present to us at our May meeting. So that'll be, I think, interesting as well. So, Sean.
Yeah, Kylie reminded me of EFSP as well. So Weld County's EFSP applications are still currently open. They're open until April 3rd. So if you provide food, shelter, emergency assistance programs in Weld County, please reach out to me and I can be sure to get you the application. It's pretty straightforward. And then, like I said, they'll close April 3rd. So that's available. And then also, it's kind of random, but the Weldway Home Landlord Engagement Group had a event on Tuesday to just meet some landlords. It was hosted at WeldWorks. It was a great event. We had some more landlords turn out than we expected, and they were the right kind that seemed to want to be partnering with agencies. But there was one partner specifically who I told him I would reach out to community partners. They own a 3-bedroom house here in Greeley, and they are looking to partner with an agency to do some kind of transitional housing program, be like a master lease and allow people to stay in this 7-bedroom unit in some kind of program. And they just were reaching out to find some partners to see if anyone would be interested in that. I don't have any other details. I just said I'd reach out and try to connect him with anybody. So I know that's challenging if you don't have funding, but if you have any ideas or thoughts or know of any agency that might be able to access that resource, please let me know.
That's great. I'm really glad to hear that landlord event actually was well attended and worked out. Maybe we can try to replicate something like that in Fort Collins or Loveland. It's always great to entice them at a brewery. Excuse me. All right. Well, thank you all so much for your time and attention. I will be sending out the minutes and recording and all of that. Oh, sorry, Brendan.
Sorry, this is so last minute here. I just wanted to take a moment real quick. I know I should have done this earlier to introduce myself. I'm Brendan Rempert. This is my first week starting as the CoC PSH grant manager for the Office of Homelessness Initiatives, the state. I believe I'll probably be working with quite a few of you in here. So I just wanted to make it known that we filled the position. I'm learning. I've got a lot to learn still, but I'm looking forward to working with all of you. So yeah, thank you.
Oh, great. Yes, we're glad that you were able to join us. All right. Anyone else? We do have time, so it's okay. It's all good if you have something you want to share. All right. Okay, well, thank you all. I will send out the PowerPoint that Sam gave, and also I will work on getting that part of the training or part of this meeting recording attached to it in case you want to share that with your team. I felt like it was very good information. So we're working on our website. The CoC website is transitioning to a new site and building it out so it has more functionality, and I would love to put those kinds of recordings on the website as well. So that's for the future. It should happen in the next couple months that we'll have that up and running, but I'll let you all know when that's ready to go view. But otherwise, have a great rest of your day. Feel free if you have questions or any follow-up, anything like that, just you can always email me. All right, take care, y'all.